A great pleasure to introduce our first speaker. So this is Emma Poff, who's a senior physiotherapist in musculoskeletal and emergency medicine in Our Lady of Lourdes Hospital in Drogheda, and who's a particular interest in musculoskeletal and vestibular rehabilitation. So I'll hand over to you now, Emma.
Thanks, Suzanne, and thanks for the invitation to speak tonight. So I'm just going to really talk about the impact of COVID-19 on musculoskeletal physiotherapy, and kind of what it was like a little bit before COVID, I suppose during COVID now, and maybe what it might be like if COVID, or hopefully when COVID ends. So next slide, please, Laura. So I suppose generally in MSK Physio, I work in a trauma centre for the Northeast in Drogheda. So we would get most of our referrals from fracture clinic, a lot of our referrals from ED, some post-op patients, and then of course we have our review patient caseload as well. And then moving on, Laura. So our orthopaedic fracture clinic would see somewhere between 17 to 20,000 fracture clinic patients per year, and they come from 5 sites. So from Drogheda, from Our Lady's Hospital Navan, from Cavan General, from Monaghan General, which is just a minor injuries unit, and then from Louth County Hospital as well, which is a minor injuries unit. And I've just put Drogheda and Louth County in purple because we actually would have taken virtual referrals from them before COVID, I suppose, hit. So next slide, please. So we initiated a virtual fracture clinic in Drogheda in 2017, just for the Lourdes Hospital initially, and then we just started to expand it towards the end of 2019 to include Louth County Hospital as well. So we were seeing something around 1,500 patients about a year. Roughly 600 or 700 of them were referred for physio. So these were a very strict cohort of patients, simple undisplaced fractures, clavicles, buckles, hands, toes, avulsions, radials, heads, and some volar plate injuries. And that was pretty much it and what we were seeing. So I suppose pre-COVID, we were actually quite lucky because we had a lot of these pathways set up already, which definitely helped us. Next slide, please. So roughly 95% of our intervention was face-to-face. About 5% was telehealth, and predominantly because it was these more simple injuries that we were seeing virtually initially, it was only over the phone that we were really able to treat them. Most of our exercise programs we were printing out during a face-to-face intervention, and we're quite old school in Drogheda. We had a really old version of physio tools that didn't have any access to email or anything like that, so it had to be printed and didn't really have any capacity to add extra exercises on or anything like that, so it was fairly limited. And then in terms of our referrals, there was small kind of increases and decreases in our referral rate over the year, so a bit busier over the winter months with ice, and just kind of some dips off with kind of pre-season and things like that. And then next slide, please, Laura. When COVID-19 hit, like everybody else, there was this instant loss of capacity in all healthcare settings. So I suppose for us in MSK Physiotherapy, in the acute setting, space was a massive thing, because our outpatient physiotherapy department shut, obviously because of infection control guidelines. But we still were getting quite a high volume of acute fractures into us, and all our post-op patients really still had to be seen. And then obviously in terms of people as well, a lot of our staff were lost, not only to, I suppose, whether it was self-isolating or kind of contracting COVID themselves, but mostly up onto the wards again. And we kind of went into shift work like I think a lot of other physiotherapy departments did. So our MSK physios, we kind of lost them as well. So there was a really big shift within our outpatient department, and obviously within the whole hospital itself, even within the fracture clinics. And then what we noticed is when society tended to open back up after lockdown, we got this really sharp demand in MSK Physio again, lots of presentations into ED and a lot more complex presentations. So I suppose in terms of how we could overcome this solution, like we know a quality service is, one that treats the patient, at the right time, in the right place, and by the right person. And we know as physiotherapists, we're more than equipped to treat most musculoskeletal injuries. So it was really imperative that we found a way to deliver physiotherapy to patients outside of the hospital, so kind of within the home. Next slide, please, Laura. So I suppose over the course of COVID, there was a lot of changes, a couple of them that I mentioned there. So we really needed to quite quickly find a way that we could, really implement telehealth within MSK Physio while maintaining those key aspects of patient care. So make sure that it was efficient, that it was traceable, that we were still getting that good quality intervention, and that we could evaluate it as well. So always kind of bearing in mind the patient, even though I suppose a lot of the time initially it was kind of like a telehealth or not solution. There wasn't that same which would you rather in the earlier days. But I suppose the creation of these pathways quite rapidly was really quite key. And when I looked at kind of other departments, even within our catchment area, some of the smaller hospitals, completely closed their outpatient physio department. And I think in Drogheda, because of the demand for within our fracture clinics, we really just couldn't afford to completely close. Next slide, please. So this is quite a busy slide really, but really it just depicts what's essential for patient-centred care. And I think this is from one of the HSE's kind of quality care initiatives. So really that time efficiency of the delivery of assessing and treating patients was really important. And then trying to find one platform that we could treat our patients through. So, patients that might come into us, especially hand patients, they might have orthopedic intervention, they might have hand therapy, and they might have physiotherapy as well. So to see if we could integrate that into one platform to make it a little bit easier for them and for the patient's carers or next kins, and to try and get them involved completely. Next slide, please. So I suppose what were the challenges? The biggest challenge definitely was the IT infrastructure, the access to computers, laptops, especially with social distancing, or if anyone has been to the physio department of Drogheda, it's quite cramped at the best of times, and all our computers are quite close together. And obviously with social distancing, especially in the earlier waves where I suppose we didn't have that access to PPE, like we weren't wearing masks back kind of in like March, April, May really. So that social distancing element was really, really important. Internet connection was a huge thing. We don't have Wi-Fi in the Lords just yet. And unfortunately, the physiotherapy department is beside radiology, so all the walls are made of lead. So even phone signal, other than the landlines, is quite difficult at the best of times. So they were probably the biggest things. And then, of course, we had to decide what rehabilitation platform we were going to use. There's so many out there, and I'm going to touch on that on the next slide. But also the patient access to IT tools as well. As I mentioned, a lot of our staff were redeployed up onto the wards. With social distancing, that was another challenge. Then we had to obviously look at upskilling staff, training ourselves up as kind of senior physiotherapists in MSK first on telehealth and things like that, and then trying to disseminate that amongst the rest of our colleagues and our staff grades. And then in tandem with the telehealth, there was also the upskilling in terms of respiratory. Most of us work on the wards, so there was all the PPE and all the extra kind of training going on there as well. Patient engagement, I think on the earlier waves this was a little bit easier because people were so grateful that they were still getting intervention. Now we're seeing a little bit more resistance to telehealth as people I think are getting a little bit fed up, especially people who've had face-to-face appointments, and now we're trying to switch them back to telehealth. And then staff engagement, obviously there was a massive change. I only graduated in 2015, so I'm relatively early on, but some of my other colleagues who are very hands-on, very manual therapy strong, and they were the people who found, I suppose, telehealth a little bit more challenging initially. And then, the big thing is the limitations of a telehealth assessment. Obviously, if there's some things that you're worried about and you just need to get your hands onto a patient to fully assess them, that's not there. And I suppose how are we going to get people, who needed direct access to a physical assessment back into the hospital? And then, as I mentioned, there was quite sharp changes in referral numbers, and I'm going to chat about that as well. Next slide, please. Next slide, please, Laura. Perfect. So in terms of rehab platforms, there's so many available out there, and we really looked into them quite quickly. So obviously they had to be GDPR or this other ISO approved. The cost, especially when you work in the HSE, is always an issue. We wanted it to be user friendly, and it needed to be adaptable to our service, because that was a big thing. We would see, because we have a maternity unit as well, we would see, any MSK, a lot of the MSK complaints through the maternity hospital, and then they would bounce back to our pelvic health physios, and similarly with our ped service as well. So we really felt that it needed to be adaptable to us, and we needed to be able to trace those patients as we referred them on to other hospitals as well. The HSE really pushed Attend Anywhere, and we tried that initially, but I suppose with Attend Anywhere you can share your screen, and you can have multiple patients on at the same time, but it was the exercise prescription element of that was a real challenge for us. I just kind of tracked out, and we ended up using a program called Slasso, which has your exercise library embedded with the telehealth function. Actually, an Irish physio set it up with her partner who's in kind of IT, and we've been using that. We found it quite good. I suppose the perk of that is when you're on a telehealth call, you can share videos of exercises. And then you can immediately, while you're on the call with the patient, you can be doing up their exercise program, and you can even do your notes on it as well. And it has all the GDPR and everything approved. But if we were to use the platform that the HSE are really pushing with Attend Anywhere, because we would have had to use our old physio tools, which doesn't have email, it really would have slowed us down. So I mean, we were looking at over 2,000 hours of extra clinical time a year, just when we looked at kind of our numbers 2020 to 2019, if we were to do that for every patient. So this was another kind of challenge along the way. And then next slide, please. So in terms of our referral flow, which I kind of briefly mentioned, so initially when kind of March, April hit, there was a massive increase in demand for our virtual fracture clinic patients, about 400% over about a week or so. So we ended up developing kind of daily trauma assessment clinics. So one of our senior physiotherapists sitting in the orthopedic kind of virtual triage clinics every morning, which meant that we rapidly expanded our criteria for who we would manage virtually. So from our simple kind of buckles, toes, hand injuries, we were now looking at shoulder dislocations, AC joints, patella dislocations, web arrays, and any kind of stable fracture that we could put in a back slab or a boot, or any soft tissue injuries. So that added a whole nother level onto kind of our telehealth assessments, and you were really relying on the ED clinician to have done a really, really good assessment, and making sure, I suppose, in terms of risk, and that we weren't missing anything via our telehealth assessment, which I think for some of our staff grades and definitely some of our students coming through, that's always the big worry, that for all of us, that's something a bit more sinister is going to be missed. And then, as I mentioned, we got this big sharp peak kind of in April, May, when everything started to open back up. Everyone was flocking into ED with a lot more complex referrals. And then the same with every kind of lockdown. So we found even with this lockdown, even though we're back in level 5, our MSK numbers have only dropped maybe about 20% on what they were in December, which is a lot less, I suppose, than we would have hoped. And we've really transitioned back to a lot of telehealth now over the last week or two. So hopefully this will start to level off towards the end of the pandemic. Next slide, please. So in terms of kind of what our successes were, we were really lucky in the Lourdes Hospital. We were able to maintain an efficient MSK Physio service throughout the pandemic, which actually meant that towards the end of kind of wave 1, we were actually had like a 1 week or less waiting list for MSK Physio service, which is relatively unheard of, where a lot of our MSK colleagues and other sites, were coming back to an extra couple of months onto already long waiting lists. We were able to rapidly and effectively develop our service and establish those multidisciplinary trauma clinics. There was a lot of staff upskilling, and to be fair, most people really did great in terms of the telehealth. And we were also able to facilitate remote working, which has been really actually important to us during this wave, with different staff, whether they're self-isolating or not. There's still a level of remote working that they can do, which is something that really, I suppose, wasn't available to us before, being so hands-on. So I think that's really been a great outcome from this point of view. We also found we had a really high level of engagement across all patient demographics. We were a little bit worried that initially that the older cohort would struggle a little bit more, but actually we found that they've been one of the best engagers in terms of telehealth, whether it's video calls or phone calls. They have actually engaged really, really well. So if we look just kind of over roughly a 6-month period in Our Lady of Lourdes, we had about 6,000 patient contacts in MSK Physio, and about 2,200 just over that were telehealth, which is really significant given the fact last year it was a lot lower. And then also, and again, we are actually looking at evaluating this. We feel that, you know, it is actually promoting self-management within the patient. They're maybe not relying on the hands-on approach as much. So hopefully that's something maybe that we can bring forward. And then next slide, please, Laura. Yeah, so just kind of a little bit of a summary. The reduction in travel time for the patient has obviously been really, really important for them. We have such a vast catchment area, especially when it comes to our fracture clinics. You know, it wouldn't be unusual for a patient to be driving an hour and a half, an hour and 45 minutes to get to a fracture clinic appointment, and then the waiting around. So there's been a massive time saving there. We've also found that as a physiotherapy service, we're more efficient, and we can do more with the same amount of time. And then we've also found that using a rehabilitation platform and a rehab program has actually also helped in terms of cost saving and in terms of the efficiency of our service. And then next slide, please, Laura. And then I suppose just kind of to finish up quickly on what MSK Physio might look like after COVID, I really think a hybrid model of both face-to-face intervention and telehealth physio appointments, definitely across the public sector, and I know a lot of private practices are looking at this as well. And then, as I mentioned, we're looking at evaluating telehealth within that wider patient cohort. And in Drogheda, we are collaborating with ORCSI and looking into this a little bit as well. So it'll be great to see the results from there. The improved access to CPD has been great. I suppose tonight is an example, and lots of other courses that we would have normally had to trek a little bit for. I mean, hopefully a lot of them will stay online, and then maybe looking at a bit more digital transformation of patient care across, I suppose, all disciplines, hopefully in the future. So that's kind of it, guys. So if you have any questions, I think